I'd like to welcome everyone to the Buncke Clinic Virtual Visiting Professor Series. I have the distinct honor and pleasure tonight of welcoming a very dear friend of mine and a very dear friend of the clinic's, Professor J.P. Hong from Seoul, Korea. Dr. Hong really needs no introduction at all, so I'm not going to spend too much time about his background because we all know him so well, but he is, as we know, professor of plastic surgery at the University of Ulsan College of Medicine and at Ulsan Medical Center. He is also what I consider to be really the world ambassador for our field. He is the man who is constantly traveling throughout the world and spreading the gospel, if you will, and operating in pretty much all corners of the world. And everyone knows him, everyone loves him, and everyone follows him on Facebook and Instagram. So he really is, in my opinion, world ambassador of our field. He is Secretary General of the World Society for Reconstructive Microsurgery. He was co-chair of the ASRM program back in 2008. And as we all know, he was a former Godina Fellow back in 2015, and he delivered the 2016 Godina Memorial Lecture. One of my favorite pictures actually is this from a couple of years ago. And this is a picture of me and basically four of our faculty within our virtual visiting professor series. You got JP Hong on the left, former Godina Fellow. We have Professor Yijin Zhang from Shanghai, who spoke to us last Thursday, also a Godina Fellow 2018. Professor Mingwei Cheng from Chang'an Memorial Hospital, the 2006 Godina Fellow. And we also had a fantastic lecture from Dongchul Lee, also from Seoul, who is master microsurgeon in the hand. JP is a phenomenal host, and he's actually hosted me, I think, at least 3 times in Seoul, and every time is an incredible experience. This was my first time to Ulsan Medical Center, and he was giving me a tour. And among many of the hats that he wears, one of them, he was the former CFO of Ulsan Medical Center, which is a massive, massive institution. But also, as I found out, he also runs the international kind of medical tourism department, if you will, of Ulsan Medical Center as well, which is also a very large department, and no better person to run an international department than Professor Hong. I had the pleasure of meeting the rest of the faculty at Ulsan Medical Center and sharing some of our experience with them and their residents and fellows. And JP, as we know, is a phenomenal host, and at every meeting, this was a Korean society, he organizes fantastic dinners and really connects people. And you've heard from a few surgeons within this picture in this lecture series. Last year during my travels, JP actually organized a trip where we both actually traveled from Seoul to India. And we visited Professor Sabapathy, who needs no introduction, and he gave us a talk a couple of months ago. And he and Dr. Venkatramani were running a fantastic diabetic foot program, which is appropriate because today's lecture by Dr. Hong is on diabetic foot reconstruction. And one of the highlights for me on this trip was to be able to operate with JP. And so the two of us did a skip flap to the foot in a diabetic man who had exposed metatarsal of his foot. This was really a phenomenal trip, and I think it's always nice to travel with friends and also to be able to experience new places. And I'd never been to India before. Many of you have seen me show these slides from the Patagonia microsurgery meeting. I had the pleasure of being one of the 2 international ambassadors or delegates for this meeting along with JP. And it was organized by Jorge Urenda. And there were a number of people in this meeting who you've heard from as part of this series as well. It was really a fantastic time of teaching and making new friends and also meeting existing ones. But whether it's tasting delicious grilled meats in Patagonia, delicious grilled meats in Seoul, here's a great Korean barbecue that JP set up, whether it's tasting delicious refreshments in Seoul, as we know JP is a fantastic host, or firing up the grill up in Pyeongchang in the mountains of South Korea for another grill session up there. It's always a fantastic time with JP. And whenever you travel with him, there's never really a dull moment, as you can see here. So JP, thank you so much for being with us. It's really an honor to have you. I'm bummed that this isn't in person. But hopefully soon we'll be able to travel again and we'll be able to spend time in person.
Thank you, Babek. I'm almost in tears. What a great introduction. And thank you for inviting me to the Buncke series lecture, Buncke lecture series. And let me just jump in, right? Let me just jump right in and sort of share our approach to diabetic foot. Here's a typical example of a diabetic foot that I see in my daily practice. Look at all this pus coming out. And I'm sorry if it's near your dinner time in some part of the world, or your lunch or your breakfast. Can you just imagine the smell behind this foot? I mean, you probably can. And I'm sorry if I ruined your appetite. But that's what diabetic foot is all about. And it's pretty startling because these patients who has diabetic foot rarely gets any formal education on how to take care of their feet. 1.3%. They rarely use any orthotics, insoles, less than 7%. And they really they don't know how to take care of their feet. Only 30% have some kind of preventive care. It doesn't end there. If you look at the startling statistics, every 30 seconds, a diabetic foot is amputated somewhere around the world. Every 17 seconds, someone is diagnosed with diabetes. 15% of these people will develop some form of ulcer. And 5 to 8% of the patients who have diabetic ulcer will have a major amputation. So to give you a more realistic number, look at this. In the US, every day, 230 Americans with diabetes will have a major amputation. 230 people. That's crazy. And you know what? It doesn't end there. I mean, if you look at diabetes, there is a 5-year mortality concept of 50%. So that means whoever has a major amputation due to the diabetes, a major amputation of the diabetic foot, in 5 years, 1 out of 2 will die, will pass away. And this is almost as bad as colon cancer. And when people talk about having cancer, everybody just freaks out and, and they're really startled. But when we talk about diabetic foot, hey, look, I have diabetic foot, I amputated. Nobody really gives that kind of empathy or the attention that these people deserve. Bottom line, when you have a major amputation because of diabetic foot, 50% will have a 5-year mortality rate will be 50%. So 1 out of 2 will pass away after major amputation. So this is why this field is so exciting for me and our team, because as reconstructive surgeons, we know we could make a little difference and hopefully improve these statistics that I just shared with you. There are 3 major components in the diabetic foot. It's ortho, take care of the bone, and then it's vascular, because you have to understand the blood flow. And then finally, it's about the coverage, which is the plastic. And as you practice diabetic foot, you'll come to realize all 3 of these components you have to understand and make part of your practice. So, and looking a little bit more closely to the reconstructive aspect, the debridement, controlling infection, is critical, because it doesn't matter if you put a great flap on it. If you don't control infection, your flap's going to die eventually. If you don't have a good vascularity, there's no recipient to use. If you reconstruct the dead skin, it's going to break off anyway. And then after you reconstruct, you have to think about the bone kinetics. If you don't correct the abnormal bone, then it's going to develop another pressure point, and then the flap or the skin is going to break down again. And then finally, there's the aspect of microsurgical reconstruction. And it doesn't end there. While we do the reconstruction, you have to constantly work with the people around the patient who really knows how to take care of their blood sugar level, who knows how to take care of their nutrition. And these kind of coordination has to be going on real time. And this is why one of the reasons it's pretty difficult to have a good diabetic foot practice. But nevertheless, once you start this practice, and once you have a common goal, then it makes it very easy for the whole team to work together. And really, an effective coordination is critical. So a lot of people ask me, So in order to do diabetes, I understand that you need a good team, but what are the key factors for team success? I mean, it's all about communication. You just have to constantly talk. And as Bobek showed at the beginning, you know, not only talk in the office, in the hospital, but also go out, have a drink together, and, you know, sort of, you know, have a nice friendship, make it personal, and then you also educate them. You understand what your roles are, and what your responsibilities are to this team. And what's really important is that you must have a common goal. And when you start to have good results, you'll definitely have the administrative support that you need. Now, in the days before this kind of good multidisciplinary approach, it was all based on consultation. So you throw the patient around to this department, a couple of days later to that department, and by the time the patient comes to you, the patient already missed that golden time to have a proper management and to salvage his feet. So this is why coordination is very important. And if you're able to have a nurse who is able to coordinate this and really figure out, hey, what's the biggest problem with this patient, and then allow this patient to go and see the physician who's in charge of that big problem, then the chances of salvaging the foot becomes much, much higher. So in our hospital, the gateway to all diabetic foot patient is the diabetes center, the endocrinologist. And there, the nurses look at the diabetic foot all the time for all diabetic patients, and then sort of triage these patients and make sure that they get the best care, best possible care with the effective coordination as soon as possible. And as plastic surgeons in the team, we have the ability to debride, we have the ability to understand wound healing, and of course, we have the ability to reconstruct the feet. And as you work with a lot of diabetic patients and these chronic ill patients, you'll understand that these patients really don't have great compliance. And even if you fix their feet up, you know, they're not going to change their lifestyle. So this is why education of the patient is very important. You have to make sure that they understand that this is their second chance and they must change their lifestyle to take care of their feet. You saw the statistics. They don't really care about their feet. But through this process, you have to educate them and make sure that they change their lifestyle and make good use of this second chance. So back in the time when I joined Asan and when we started the diabetic foot team, our major amputation rate was really high. It was almost 22%. And we put a goal together as a team, say, let's reduce the major amputation rate of these patients. And that was the common goal that everybody sort of came together and to work together because it was a common goal that allowed us to have better results and at the same time allowed us to have a better reputation as a whole team and then in looking at the bigger picture as a hospital. So we got together and set this common goal up to reduce the major amputation rate. And again, diabetic foot is a very complex issue, and the spectrum of the treatment is really, really wide. It's from taking care of the blood sugar, and on the other extreme, it's the amputation. So we're just going to go briefly touch on these wide spectrum because these are all very important, even as a reconstructive surgeon, to learn what other people are bringing to the table, and also as the first line when seeing the patient, we have to understand who to send to, who to ask help, who to ask for help to. So first of all, it's about nutrition. So we always look at every albumin level. Now the nutrition is very important because without proper nutrition, even if you put out beautiful flap, it's going to take a long time to heal. So we have to make sure the patient has enough fuel to fight this grueling reconstructive process. And this is why looking at the nutrition is very important. Also making sure that patient controls the blood sugar level pre and post operation is also very important because without proper control of blood sugar, there's a very high rate of post surgery complication and also a very high rate of recurrence. So now with the help of IT, we monitor their blood sugar level real time. And when the patient is out of the targeted blood sugar level, they get an automated text and we're able to help them control. And as seen by this publication, from our colleagues, doing IT real-time monitoring really helps to control the HbA1c much faster and much longer. In addition to this, now we're using IT technology to have a smart scale that's able to monitor temperature and also is able to monitor foot pressure. So using this also give us an idea whether or not the patient is having inflammation or the patient is having problems with their skeletal structure, and allows us to see the patient a little bit more early. I cannot emphasize more on education and prevention. These are the typical video on YouTube or on our website, or on our hospital website, to educate the patients and tell them the importance of vascularity and how to take care of their feet. This is a small booklet that we worked with our Wound Healing Society, and which is for the patients to take home. Also, we do campaigns with the government. This is touch your feet for 2 seconds and see whether or not the feet is hot. And if this is the problem, then go see your doctor. So these kind of education and these kind of simple education, very short procedures that the patient's allowed to do, will help them sort of take better care of their feet, at the same time realize if there's an early problem. So these are the things that's going on even before the patient comes to the hospital. Now, when the patient has a small wound, the good standard of care is, again, controlling the infection, making sure the dead tissues are debrided, using proper dressing, checking the vascular supply. If it's an ulcer on the plantar surface, offload as soon as possible. And if the feet has swollen up, address the edema issue. So these are the things that we constantly educate our nurses to do. We not only educate the nurses who's the coordinator of the diabetic foot team, but also we educate at least 1 or 2 nurses in every ward to see if their patient with the diabetes have these kind of problems. So continuous education, surveillance through nursing resource is an important part of taking good care and a preventive measure for diabetic foot. And when you're working in a big hospital, the team has to also communicate very clearly. There's so many different classifications for diabetic foot, and you have to make sure that you're all on the same page for the sake of communication. So we adapted the University of Texas classification. So when we say 2B, it means the wound is up to the tendon or the capsule, and the wound is infected. So everybody's on the same page. So when we say 2B, and then everybody knows it's 2B, and then they do their part to help the patient. So for example, the infection doctor will take a look at it and order proper antibiotics. Also, for all diabetic foot, we never swab. We always take tissue samples, and that's the thing that we agreed as a whole hospital, because swabbing does not really have a good specificity. So making sure that we want the best result, we always take tissue samples. So when we look at a biopsy, the ones that even we didn't do or other departments did, we always know that this is a tissue biopsy, and we find it's very reliable. Another thing that you have to come to an agreement as a team is the use of broad spectrum antibiotics. We want to make sure that the patient does not develop any resistance. So using the first line, second line, or the third line antibiotics has to have some kind of common agreement. So this is very important to manage the patient, even though the patient goes through different departments. So making sure that you have a proper assessment, making sure that you have the right debridement, making sure that you have a common understanding for using proper antibiotics is a very important part. In addition, when you debride, these are the things that you have to aim for, making sure that you remove all the dead tissue. So this is basically the good standard of care, and the good standard of care should be given not only by your team, but the whole service in the hospital. Also, another important thing is documentation of wounds. Now, when I first started, I just saw it and I said, oh, it's getting better. And I wrote, it's getting better. But based on what? All the documentation has to have a very objective finding. So looking at the reduction rate of the wound itself is very important, because we know that looking at a wound, if the wound is not decreased in size of more than 40 to 50% within 4 weeks, then we know that this treatment is not working. So you have to change your treatment protocol. And this is why the concept of measuring size is very important. Nowadays, you could use these kind of digital cameras. They will automatically give you a 3D volumetric value. So that also plays a significant role to actually monitor these wounds very objectively, as you can see here by the paper published. So these are the basic things that you have to take care of. Now, when simple debridement and controlling infection and using proper dressing doesn't work, as plastic surgeons, we have a lot of tricks up our sleeves, from stem cell to growth factors. These are the things that could add to non-healing wounds. We just talked about you have to look at the wound, whether it's being reduced in the first 4 weeks. If not, then you have to change the regimen. We use tons of MPWT in our practice. The only thing you have to be careful in treating diabetic foot is whether or not the diabetic foot is ischemic. When the diabetic foot does not have the regular oxygen perfusion, then you have to lower the pressure. So these are the difference in using MPWT, especially in less ideal patients. We also like to use MPWT in these kind of more simpler patients that require that may be indicated for flaps. And as you can see here, this patient has an exposed tendon and some part of the bone. So in this case, what we like to do is we like to use a synthetic scaffold like Integra, and then put the vac on it, and really allow rapid granulation. For these kind of cases, you could get away, instead of doing a full local or free flap, but get away with this with a skin graft after using this kind of scaffold simultaneously with MPWT. There's a lot of talk on hyperbaric oxygen. And for us, hyperbaric oxygen is a very important indicator for demarcation. We all know how the oxygen works in ischemic diabetic foot. This is the oxygen chamber that we have. Around 10 patients could go in there, chat with themselves, and then basically they go for a 90 minutes to 120-minute hyperbaric dive. But our goal is not to really heal the wound, but our goal in using hyperbaric oxygen is to allow demarcation between the poorly circulated tissue and the well circulated tissue. A lot of the times you'll be seeing patients, the one on the left, and you can see here that the demarcation is not clear. And when you close these wounds without knowing whether or not the surrounding tissue will heal, then this patient is going to have complication after complication after complication, and may even end up having a major amputation. So compared to the tissue oxygen, when it's 6 millimeter mercury, look at it after 10 weeks of hyperbaric dive, how clear the demarcation is, and the surrounding tissue is more than 40 millimeter mercury. So having seen this, now we understand where the clear amputation site should be, and that will allow healing as well. And the same thing goes for flaps. If we don't know the exact territory, then we do a lot of hyperbaric dives to give us an idea between the dead tissue and the surrounding well-vascularized tissue. We also were very fortunate to work with a growth factor, namely the epidermal growth factor, which allows fibroblast proliferation, migration, along with keratinocyte migration and proliferation as well. And through this clinical trial, we've actually shown the efficacy of the healing in grade 2 ulcer, as seen by this graph. So here, in patients that did not heal for 4 weeks, then we add on the epidermal growth factor, and with the addition of this growth factor, we're able to achieve healing after that period of time that didn't heal with the regular good standard of care. I wish all my patients were this simple, but the reality is a lot of the patients that you'll face is these kind of patients. Patients with clearly an indication for reconstructive microsurgery, or at least for a flap surgery. So these are the patients that we see. So as plastic surgeons, we not only could contribute to the team by doing debridement, by doing wound healing, by doing simple surgical procedures, but by doing microsurgery and flap reconstruction, this is the biggest contribution that we could make to salvage, which is a critical part to salvage the limb. Nowadays, we've moved on even beyond reconstruction, now doing TMRs and RMPIs, and really allow to have the patient, even after amputation, the best possible rehab and really get back on their feet with prosthesis. And this is also the background for future robotic prosthesis as well. We also have the capability to make amputations better, more functional by doing these kind of TMRs and RMPIs. So the role of the reconstructive microsurgeon is now expanding, not only by providing soft tissue coverage, but also addressing a functional reconstruction, even for amputation using TMRs and RMPIs. And this is why it's so exciting as a reconstructive microsurgeon to be involved in the diabetic foot. Nevertheless, the purpose of today, for time's sake, we're going to be focusing on the reconstructive aspect of the soft tissue. And the purpose of all reconstructive surgery is, of course, cure the wound. For diabetic foot, salvage the foot, make sure the patient could use his foot to preserve gait, provide an alternative to amputation. And by doing this, we're able to heal the wound faster. I mean, you could put a vac on for 2 years and the wound may or may not heal. And there are documents where actually showing these chronic wounds being treated with vac for more than 6 months, more than 12 months. Vac is a wonderful tool. But if I were the patient, I'd rather have flap surgery and then go back to my life within a month or two. So this is the value the reconstructive microsurgery brings to the diabetic foot care. And of course, ultimately, it's providing the patient with the right second chance. Now, we all talked about the large spectrum of diabetic foot, and the same thing goes for reconstruction. When the patient, think that we'll have to go under reconstruction, and you have to look at the systemic condition, and then you evaluate the wound. Of course, looking at the systemic condition is controlling the blood sugar level, making sure the patient doesn't have infection, making sure the wound bed is prepared for a reconstruction, making sure that there's no major heart problems, and of course, I cannot emphasize more on the nutrition. There are documents from the Georgetown group showing that if you don't have a good blood sugar control, there is a statistically higher chance of dehiscence and reoperation. So this is why it's critical that you should control your blood sugar level during the process of reconstruction. The main indication for microsurgical reconstruction in our team is when the patient has an ischemic wound, because we know that ischemic wound is going to take a very, very long time to heal. As long as the patient has a major vessel intact, then we always aim for reconstruction, and we'll be getting into more details in a bit. When the healing process has stopped for several weeks, even with good standard of care or even using vac, then we consider for reconstruction. When the bone is exposed or the bone is infected or other vital structures are exposed, of course, this is indicated for any flap surgery. And when these wounds are just too complex and extensive. And that's the major indications that we have. I mean, if the conservative care works, if the local flap works, that's great. But even if you're considering this patient for a local procedure, unless you're certain that the vascularity is good, it is very recommendable that you evaluate the vascular structure. Sometimes having too good pulsation is enough, but sometimes that could be a very tricky situation as well, as I'll be showing in the later photos. So the first thing when you're considering the patient for reconstruction for local flaps or even for free flaps, it's a must for free flaps, you have to evaluate the vascular status. Now, doing this, you could use a CT angiogram, which is really great because it shows you where each portion is calcified. And it's really a non-invasive measure. It's a quick, simple way to look at it. So CT angio really works well. You not only look at the lower leg, but you must look at the whole entire leg, because a lot of the times in the proximal thigh or in the thigh, these major vessels, the femoral artery could be obstructed, And there could be, during that time of obstruction, slow regeneration of collateral vessels develop. And ultimately, these patients, despite the fact of having obstructed femoral arteries, have a good collateral, so they're still having good distal flow. What does this mean? It means that if you take the ALT, which is the major collateral of the femoral artery, then you're going to lose the entire leg. And this has been reported in a case report a few years back. So looking back at evaluating not only the lower leg, not only the feet that has diabetes, but also potential recipient site is very important to maintain a good flow distally in the diabetic foot patients. Now, if you do find a vascular obstruction or a vascular anomaly or defect, you must consult with your vascular surgeons or your interventionist, whoever it may be. Sometimes it's a radiologist, sometimes it's a cardiologist, sometimes it's a vascular surgeon. Nevertheless, we always try to get the best flow by doing angioplasty first, and then if angioplasty is not possible, then by going through a bypass. What's really great is that when the patient undergoes these kind of angioplasty, the flow velocity increases about 15 to around 30%. So this really allows you to have the maximum flow to the feet, making a better environment for healing, and also allows you to choose the best possible recipient vessel that has an increased velocity. So making sure this getting the best possible vascular environment for reconstruction is critical. Now, once you've improved the vascular level or see that there's no anomaly or abnormality, then you could consider local flaps or free flaps. So in cases where we maximize the flow and it's indicated, then we go ahead and start planning our reconstructive procedure. And in the OR, everything starts with a proper debridement. Now, debridement is especially important in patients that has an ischemic component, because if you debride just the defect, and if the surrounding tissue after you put the flap on does not really have good vascularity, then you're going to have an island of a surviving flap, and you're going to have necrosis around the margin. So you're just going to have a floating island skin flap, and ultimately this is going to also have trouble. So it's critical that the surrounding tissue where you're going to put the flap on has a good vascularity. So how do we know that we're going to do a good job with the debridement? And this is where the concept of angiosome related debridement comes in. So debride the whole angiosome territory with the defect. Then we know that the surrounding angiosome will have a better flow, and then ultimately we'll have a better chance of enosculating the flap on the territory of the defect. And you can see that. And what's really interesting is that these ischemia pattern always follow the angiosome territory. So debriding with the angiosome concept is very important. Second is when you decide to do reconstruction, it's very important to prepare the wound adequately. And we like to do this because in the feet, you see there's a lot of chance for small dead space. And in these small dead space is where the bacteria usually forms. So by using NPWT, you're able to have a very solid granulation and able to fill these void of potential dead spaces. So this is the concept of preparing the wound. And I think using the NPWT, as you can see here, between these two pictures, you get the upper one with dirty granulation compared to when you use a granulation with serial debridement, you get this kind of clean wound, allows a chance of better survival with the flap without having postoperative complications such as infection. For the diabetic foot patients that I reconstruct, I like to use skin flaps. Of course, you could use muscle flaps for your preference, whatever you're comfortable with. They're both great flaps. And if you look at literature, they all have their advantages and disadvantages. So be comfortable of which flap to use. For me personally, I like to use perforator flaps. I like to use thin skin flaps because I do believe that they provide a better anchorage and they resist better to shearing compared to muscle. I like to use a lot of times ALT or the skip, or the for the plantar surface, I like to also use the buttock skin as the source of my flap. Now, again, the most important part is finding the recipient where you're going to put the free flap. So for these cases, you need at least one viable a major vessel. And if these vessels are calcified, then you have to find a segment that is not calcified. Sometimes you may have a whole entire vessel that's calcified, but if this axial artery is patent, then there always will be a segment of non-calcified portion, and that's the portion that you want to work on to hook the flap on. I like to do it end to side because I think preservation of the distal flow is very important. So that's the part that you have to find with no calcification. Or you could find a branch from the major artery and you use the branch to do an end-to-end. Or when it's an amputated stump, find a major vessel and then you hook it up end-to-end. So here's a typical case of microsurgery. The patient has first ray ischemia. After a reperfusion doing angioplasty, the feet suddenly undergoes ischemia reperfusion injury. So that means there will be a lot of inflammation post angioplasty. And this is why you must debride early after the angioplasty, because if you let that inflammation period go, then you're going to have uncontrolled infection that goes all the way proximal to your leg. So it's very important when the leg has a better circulation from ischemia that you do the debridement within a couple of days. So we debrided the first ray entirely. We were able to salvage the bone on the first toe, elevated a ALT, and this is the final result after 10 years. And you can see that we're able to salvage the first toe, which is very important, critical in gait and having a good gait. And we're able to have this kind of nice functional result without any secondary debulking procedures. So this is how we're able to salvage diabetic foot. We talked about calcification, and a lot of the times a patient will have these kind of calcified vessels. Now we learned that the diabetic foot will be neuropathic diabetic foot or ischemic diabetic foot, but the reality is 70% is neuroischemic. So there's always a component of the ischemic vasculature, and this is why I highly recommend getting CT angio, as seen in this patient here. And when you open up and we decide to use the dorsalis pedis, you can see that this intact dorsalis pedis have severe calcification, but that's the segment that is spared from calcification, so you could hook up your flap end to side on that. We made a small hole, making sure that there was good flow, and then we stitched it up. And then we're going to use that place right there to hook up our vessel. And that's the, again, patient ALT, and that's the final result, using the calcified spared segment to do the reconstruction. So the idea of using microsurgery in these patients are you have to have at least one major vessel intact. Even if it's calcified, you're able to find a calcified spared segment. And prior to reconstruction, you must maximize the blood flow to the feet by doing angioplasty. So that's the basic idea of doing reconstructive microsurgery on diabetic foot. And in our hands, our flap survival rate through this kind of microsurgical procedure was about 91.7%. Our limb salvage rate was 84.9%. And our 5-year survival, as you can see here, doubles the 5-year survival of the BKA below knee amputation population. Now, you might argue saying that, hey, look, maybe the patient that underwent amputation had a worse systemic condition. And we looked at both groups with the American anesthesia score, and there was no difference. So having the opportunity to salvage the limb is critical in having this patient's not only a better quality of life, but also to increase their quantity of life. And this is just not my statistics. Our friends in Georgetown also had a similar statistics where they showed preservation of the foot is synonymous with 5-year survival. We also looked into what are the risk factors in regards to successful flap. Now, the patient with One artery, as you can see here, is not significant, so it is okay to do it. A patient with multiple angioplasty or peripheral artery disease had a higher odds ratio of having failure. So when you start doing diabetic foot reconstruction, maybe patients with complicated vascular disease are the ones you want to avoid in the beginning. But as you get used to reconstructing the diabetic limb, then these are the patients that you ultimately have to challenge yourself. One other significant factor was patients that are using immune suppression agents. They had a 22 higher chance of getting a complication, and this is because after KT, a kidney transplant, when they're using immune suppression, infection is really, really hard to control. So this is why wound preparation through proper debridement and making sure that the wound base is well granulated using MPWT really helps to have to address these kind of patients that are using immune suppression agents. And again, in the beginning, you might want to avoid them, but if you have to, think about the basic principles of getting the wound ready, controlling the infection, the principle of good care in regards to treating these kind of patients. But what about these patients here? What about these patients here? I mean, it is obvious that this is an ischemic diabetic foot, and ischemic diabetic foot means that they have very poor vascularity. If there's no major vessels, do we just give up? Do we just amputate? And this was the next challenge that we took on, and then basically came up with the idea of using supramicrosurgery concept. Supramicrosurgery, we all know that it's using small vessels of less than 0.8. Most of the times it's perforated anastomosis in our practice. It's sometimes could be LVA. But I started to look into the possibility of using these small vessels in ischemic diabetic foot. Now let's go back and talk about the angiosome of the foot again. Angiosome territory is 6 very distinctive territory. Now we talked about ischemia following the angiosome territory. And even in patients that do not have major vessels, no posterior tibial, no dorsalis pedis, somehow other parts other than the ischemia are relatively pinkish. They're getting some kind of blood flow even though there's no major vessels. So how do we explain that? We can explain it by looking at this patient here with poor vascularity, and then we know that even though this patient has ischemic limb, the surrounding tissue is quite pinkish. And we did further study looking into what happens in the process of ischemia. And what we found out was once the major vessel starts to be obstructed more than 75%, we slowly see sprouting and formation of collaterals. And as it becomes fully obstructed, then the numbers of the collaterals suddenly significantly increases very fast. So knowing this idea, we start to think about why don't we use these small collateral vessels or the perforators that are being supplied by these collateral vessels as recipient source. And that's how we got the idea. So ultimately finding the recipient vessel, we also found out was that it needs to have at least 15 to 20 centimeters per sec velocity in order to adequately provide flow to the flap. So using this idea, we started to do reconstruction in ischemic diabetic foot. Remember, prior to reconstruction, we always do hyperbaric oxygen to clearly demarcate the wound as much as possible. So here you could see that after amputation of the lateral rays, look at the digital artery. You can see the digital artery is quite nice. On the right, look at the angiogram. The angiogram has really poor flow below the ankle. But after angioplasty, you can see that the collateral vessels open up, and then we're able to see some vascularity to the foot. And now knowing that there is a nice small vessel on the foot, we target these as recipients. And in this case, we elevated the posterior interosseous artery perforator flap to reconstruct the web space. in the left, you see that in the digital artery, we opened it up end to side, and then we're hooking up the flap. And we elevated the flap on the right. And you can see that there's a very nice artery and a collateral vein for this flap. After elevating the flap, we take it to the foot. And on the left, you can see that we already finished the anastomosis. So look at this. Even though the patient has no major vessels, this perforator is being supplied by the newly formed collateral vessels. I always like to do the vein first, and then do the artery. And after doing the vein, look at this perforator. When we cut the perforator, look how good the flow is. And remember, this patient has no major vessel, no dorsalis pedis, no posterior artery. And when we cut the artery, you'll see a nice flow. I always like to dilate my arteries, dilate to a very comfortable diameter to do the anastomosis. When you cut, look at that. Imagine, this is not from the dorsalis pedis. It's just from the collateral vessels. And when you have this kind of flow, why not use it to do the reconstructive procedure? So that's what we do. So look at that. We're able to salvage as much as foot as possible. The same principle. Now, this patient looks inflamed because of angioplasty. Remember, after angioplasty, the soft tissue undergoes ischemia, reperfusion injury. So quick debridement, using the skip, using the perforator coming out from the medial plantar, and then this is the final result without any secondary procedures. Similar concept. After amputation, the dorsalis pedis is calcified, you can see in the picture. And so we use a small collateral vessel from the dorsalis pedis. Even in the reconstruction of the first toe, we don't amputate these kind of exposed bone wounds anymore as long as it's clean. We try to salvage the first toe, which is critical in the gait process. This patient, which has a ischemia distal foot, after hyperbaric oxygen dive, you can see clear demarcation. We amputated part of it, elevated the ALT, prepared the wound, and then this is the final result. So the patient avoids major amputation and is able to use his own feet to ambulate. So the idea of supramicrosurgery is maximize the blood flow. Despite the fact that there's no major vessels, rely on the collateral circulations. These are enough to supply blood to the tissue. And then find a nice recipient source with about 15 to 20 centimeter per sec or more velocity. And then you're able to do this kind of supramicrosurgery. Our flap survival rate in this series was about 90.5%, and overall limb salvage rate was 93.7%, even in ischemic diabetic foot. So now we're able to really push forward and looking at the risk factors because we're using small vessels, the risk factors in regards to major vessel condition is now far less because we're not using major vessels anymore. We're using small collateral vessels, which really reduces the risk of having a flap failure. Now, what was also interesting is that the heel is very difficult to reconstruct. And what we found out was that the heel is being supplied both by the lateral ankle peroneal artery system, the lateral tarsal system, and also by the posterior tibial. And a lot of the times when both of these arteries are not functioning well, the surrounding angiosome is very poor. And this is why the heel reconstruction is very difficult. So a lot of the times you have to debride aggressively. So despite the fact that the heel has around only 73%, which is far less than the other regions of the foot, as long as you debride widely and use a good vessel, we usually take it from the anterior tibial artery and then have a long pedicle reconstruction, then your chances of having a better outcome will increase, even though it's a heel reconstruction. The postoperative care, of course, is a subjective observation of the foot, of the flap, making sure that the patient does not have increased CRP, which is critical in finding whether or not the patient will have early infection. Now, you will sometimes see late flap failure in these diabetic foot patients because, of course, their immunity is low. Sometimes we could lose a flap as long as 3 weeks out. And this is all because of late phase infection. A pocket full of hematoma could lead to infection. So it's very important that you monitor the CRP. And we like to use the duplex ultrasound for that purpose, not only to have objective monitoring of the foot, but also making sure that there's no hematoma collection underneath the flap as well. So duplex ultrasound is now becoming a critical part, not only preoperative, intraoperative, but also in postoperative monitoring of the flap as well. Now, this is to show the importance of teamwork, especially with your intervention specialist. Now, if you look at literature, after the patient undergoes peripheral artery intervention, reocclusion rate could be high as 60% within 2 months. So what does this mean? So this is why after angioplasty, if we are satisfied with the result, then we basically do the reconstruction within a few days, because we want to maximize the window of the vessel being open. Sometimes the vessel can close even after a couple of days. So this is why when you suspect a sudden change in the vascular flow, you have to reconsult your interventionist. So here's a case here's a case that we did on the plantar aspect of the foot. You can see that after angioplasty, the patient has a relatively good vascular flow. So we went ahead and we did the skip flap. And then suddenly on day 5, it has this kind of appearance. And then we looked at the angiogram, and what we found out was that there was an obstruction right on the recipient side. So we asked our interventionist to open up and do an angioplasty again. And after opening up, we see clear. Now we're able to see clear flow to the flap. So this is what happens. It's not because there was a technical fault of your anastomosis. Sometimes it can be, but by doing another angiogram, it will show you whether or not the obstruction is occurring more proximal to your anastomosis. And if that's the case, you have to quickly open up the vessel, and then after you open up, you're able to salvage the flap. So going back to one of the early slides, I think we talked about how important it is to understand other fields. And as reconstructive surgeons, we have to understand in a little bit more detail about skeletal side and as well as the vascular side. Now, this was the algorithm of the approach that we do. And we also talked about how large the spectrum of care is, and it is essential to really have a good team. So going back to our early slides, our major amputation rate was 22% with great teamwork. And with the reconstructive microsurgery and super microsurgery approach, now our major amputation rate has reduced to around 2.4%. So now we're able to salvage all foot that as high as 97% in our patient population with ulcer. So where are we going from here? I mean, are we done? Are we near perfection? I don't think so. I mean, we talked about how important coverage is, and we also looked at, what is the effect of the flap to the surrounding skin, especially in ischemic patients. So a lot of the cases, a lot of the times we say, oh, the flap, probably will be will improve the surrounding tissue vascularity, and nobody really looked at this. So we did. And then we looked at postoperative 6 months, and what we found out was that it does indeed, when we compare it with the amputation group, it does indeed increase surrounding oxygen level of the surrounding tissue around the flap. It has a almost double the oxygen level compared to the amputation group. So this was pretty amazing finding. So and all these patients underwent angioplasty the same way. Immediately after angioplasty, their oxygen content level goes up to about 40. And then after, when we follow up after 6 months after reconstruction, the amputation group, the oxygen content level goes down, while the flap group, the oxygen level continues to rise to around 60 millimeter mercury. So that when you do put on a well vascularized tissue on the ischemic foot, this will help to have a better circulation around the ischemic foot as a total. So this was something that we found to be remarkable. Also, we are learning more and more about the importance of the skeletal management. So here's a patient that undergoes reconstruction after a metatarsal amputation. We think we did a great job, but upon follow-up, look at this. The patient is having ulceration on its forefoot. And the reason for this is because the patient had a tight Achilles. So instead of addressing, I mean, of course, in addition to addressing the wound, what we did was we released the Achilles, and now the patient does not have any ulcer on the forefoot. And this is why understanding the kinetics is very important. And nowadays, during the reconstruction, we also address these tendon issues or the skeletal issues to make sure that the patient will not have a recurrence of the ulcer. So it's very important to understand why the ulcer occurred. Was it a tendon anomaly, or is it a skeletal-based anomaly, or is it a vascular anomaly, or is it others? So understanding the cause of the ulceration, addressing the cause, in addition to reconstruction of the soft tissue, is a critical part in regards to future complications. So nowadays, we call this functioning reconstruction because we have to think about the functioning aspect. It's not about just putting skin on. It's not about just doing the soft tissue, but it's also about addressing the functioning aspect of the foot. So knowing your function is very important. So this works both ways, actually. So when we started to do a lot of reconstruction, I mean, we thought that salvaging as much as possible would probably be better. And it turns out that from our orthopedic colleagues that this is not really a good reconstruction because ultimately, after 10 years, this patient will have a medial deviation of the fifth and the first ray. And when this continues, the patient will ultimately have an open joint. So that means the patient will undergo some form of amputation after several years. And this patient was after 10 years. It's still doing well, but there's definitely a medial rotation. So our orthopedic colleagues recommended that we do transmetatarsal amputation from the beginning. So we went ahead and saw if that was the case. And we went ahead and we started to do our review, which we published in PRS a while ago. And then it actually turns out when the patient has remnant toes, the function of the gait is good during the time of that remnant toes. But also what we found out was that the patient with these remnant toes will have a higher rate of complication. So now with this data, we're able to tell these patients, okay, if you have a transmetatarsal amputation and reconstruction, then the chances of you having additional wound problems or toe problems will be less, but the quality of the gait will be poor compared to the toe preserving surgery. So this is the data that we have, and now we're able to give patients a clear understanding and have them involved in part of the decision-making process. So are they willing to have minor complications later on, but have better function of gait? Or are they don't want complications, or they just want an amputation with a less quality of gait? So this is the kind of things, when you think about function, that you're able to bring new facts, new evidence to the table, and with this new evidence, help the patients to further make their decision. So this has been my overall experience and review from our team at Asan doing the diabetic foot. I'd like to thank Greg Buncke and Abek once again for the invitation of me to be your visiting professor, virtual visiting professor. But you guys do owe me definitely a beer, a cold beer, in the future. Finally, I want to thank my team, Peter and John, who's always been my dear friends and a huge team in addressing these kind of complicated diabetic foot. And with that, I'll be more than happy to open to any questions. So thank you very much.
Thank you so much, JP. I think we owe you more than just one cold beer, many cold beers. And this is in no way in lieu of an in-person visit. So we certainly would love to have you in person as well once all the kind of travel restrictions have been lifted. Thanks again for another fantastic talk. This is the second talk you've given us as part of the series. The first one being on lymphedema, and I invite anyone who is interested in that to come to the website and check that out as well. I think part of the reason, JP, that I really wanted this talk as part of our series is because I think of all the topics that we have covered, this is, I think, one of the ones that potentially even makes the most difference around the world for so many patients. So talk about something that actually affects millions of people's lives every day. And I think one thing that you have done is that you have really spearheaded an effort to tackle an unsolved clinical problem that traditionally wasn't seen as a very sexy problem, right? This isn't, nobody finishes residency or in the past said, oh, you know what, I want to be a diabetic foot reconstruction surgeon, right? But you showed that it's not only possible, but that you can also apply the latest advances in techniques in perforator flaps and perforator microsurgery to really make a big difference in patients' lives. So congratulations on that. I think it's something that we've all seen you develop, and I think is very commendable.
I mean, think about it. I don't know how many patients want transgender, but definitely millions and millions of people have diabetic foot. It's a huge market if you look at from the financial aspect. But I think even more so than that is the fact that we can make a difference in changing the patient's life, in helping them live longer and live better. I mean, what field of plastic surgery is directly related to 5-year survival? And if
Yeah.
we're able to do this, I mean, as plastic surgeons, this is a huge contribution to patients with diabetes and diabetic foot.
Yeah, no, I think like you said, I mean, we're usually in the even what we do with hand trauma, it doesn't necessarily prolong patients' lives. It improves obviously the quality of life and gets them potentially back to work and that kind of stuff. But I think what you've shown with your data is that you're actually prolonging patients' lives, which obviously in this case is really important. A quick question, which is more of a kind of a high level question. You clearly have developed a very cohesive, well integrated system for these patients to be seen by not only you as a reconstructive surgeon, but obviously your podiatrists and your vascular surgeons, and run by many of the nurses and so on, and endocrine providers. And the question for you is where does someone start? Let's say someone is at a hospital that has a lot of diabetic patients, and let's assume maybe they have a wound care center. Where does one even start? What's the basic building blocks of trying to get this off the ground?
Yeah, that's a very good question. I mean, as a plastic surgeon, we manage bones quite frequently. I mean, not big bones, but small bones. So understanding the kinetics of the tendon and bone, I think, something that is very doable. I think what we're not really able to address is the vascular issue. So if you really want to start small, I think the most critical partner that you need is your vascular interventionist. So again, bypass surgery is not a primary approach anymore. So whoever does your vascular intervention, for example, a radiologist, cardiologist, or vascular surgeon, who it may be, I think that's the person that's most critical. And then if you want to add on one more, it's the endocrinologist, because these patients have, a lot of the times very severe systemic conditions. And as plastic surgeon, as a surgeon in general, we're not really comfortable addressing these critical, systemic conditions medically. So having that that endocrinologist who's able to address that systemic medical issue, I think is also will make your life much easier. So I think those are the three, people that you really want to work with: the endocrinologist and the interventionist and yourself.
Hmm.
That, is more than enough to really start a very, very strong practice. So I recommend that, you gather those two other partners and then you start up. You don't have to necessarily be, located in one location. But as long as you have your phones and you're able to communicate freely, just call them, text them, say, hey, look, this patient's on your way. Can you see the patient? And as long as you have an understanding, then I think that will make a huge difference in the overall um, outcome and the overall provision of this kind of solution to the patient.
Yeah, those are great points. Now, you also mentioned earlier in your talk that you do, or your kind of system there does remote surveillance of the patient's blood sugar levels and so on. I would imagine that remote surveillance, especially now in the time of COVID, is even more important. Have you guys expanded that beyond that to even flap monitoring or monitoring of patients' wounds beyond just the finger sticks?
Yeah, this is it's a very good question, and I know that you guys do remote monitoring through. I think that is it the Vioptic system? Is it
That's the one that
right?
has an app that you can follow remotely. Yeah,
Right. Yeah. So those are really great. Unfortunately, in Korea, these kind of remote systems are not being properly reimbursed.
got it.
So from the financial perspective, it's very, very difficult to set up these remote systems. I mean, the reason why we have the diabetes blood sugar monitoring is because it's a huge social impact, and the government does reimburse partly for that, and the insurance, other private insurance company does reimburse, but for the flat market, it's such a small market. I don't think we'll ever have reimbursement, and that's a big hurdle that we are facing right now. But I think in your market, definitely this would be something to use in other markets who's able to have reimbursement of these remote systems. I think would be really fantastic. That would allow you to discharge your patients early.
Yeah.
But for diabetic foot, when we compare with our trauma cases or with our cancer cases, for cancer cases, we usually discharge them on day 4 max. But for diabetic foot, we usually discharge them after about a week or 2. For some reason, we're not comfortable with discharging them early because they need more
Mhm.
antibiotics, prolonged antibiotics, better care with the blood sugar level and other systemic conditions. So we end up having them for at least 1 or usually a couple of weeks, and a couple of weeks is enough to to have a good idea whether or not the flap's going to survive or not. So in our situation, the necessity for a flap monitoring in diabetic patient, I think it's a little bit less. But I think this is definitely the way to go forward with remote monitoring.
Yeah, that's a great point. I think one of the most interesting part of your talk is hearing about how our traditional concepts of the vessel depleted leg, for example, or lack of major 3-vessel runoff is usually seen as a contraindication of pre-flap surgery in the lower extremity. And what you've shown is clearly that that's not necessarily the case. I think if this is a trauma case, for example, it's very different. But in a diabetic who has had time to develop collaterals, that you can oftentimes find good perforators that have really good flow. And you also showed that even in segments that are calcified, you can still find little areas and do little endocyte anastomoses. Usually with our free flaps, we basically just do maybe a baby aspirin for a few weeks. Do you add anything for these patients with calcified vessels? Do you use heparin? What kind of thromboprophylaxis do you use for these patients?
Yeah, that's a very good question. So most of the ischemic patients, usually will always um almost always will undergo some angioplasty procedure.
Hmm.
And after angioplasty, the interventionist always use low molecular weight heparin
Hmm.
as their post-op regimen. We don't taper them during surgery. We just have them on. We just, a little bit more careful and more meticulous in the coagulation and during the debridement. So we don't need to add on any anticoagulants post-op because it's already there, and we just keep the intervention regimen, and try to maximize the flow as much as possible.
And do you know how long they're on the Lovenox post-operatively or post-procedure?
So right, during the time of admission, they're on low molecular weight heparin IV, injection during the whole time of admission, and after that, I know that they changed to aspirin after the discharge, and they take it for around 3 months.
Got it. Great. The other question I had was, what are your thoughts on adjunctive modalities for wound care, such as Integra or other topical dressings, wound healing products that are out there? Do you ever use these in conjunction with your free flaps? Do you ever use them in lieu of a free flap? What are your thoughts on those?
So, again, I talked a bit on how to prepare the wound, getting the wound ready for free flap,
Mm-hmm.
because, the better granulation. I mean, when I see, granulation, first, I want to make sure that all these small dead spaces are, packed with fresh granulation.
Mm-hmm.
And when I do see granulation, I also know that, this patient has now a relatively good circulation. When you
Mm-hmm.
don't see granulation, it's a sign of ischemia. So we send the patient back to our interventionist and say, hey, look, we're not seeing any granulation. We need to improve circulation. Also, we measure the velocity of the vessels, but also we look at the state of the granulation. Now, that being said, if this patient needs to go under a flap and I want to see granulation, I use a lot of the times Integra. And I think Integra really helps to granulate the wound faster. I mean,
Mm-hmm.
if I'm not gonna do flaps, and if I'm just gonna have granulation and skin graft, of course Integra is the key component. I mean, is an important part to enhance the granulation and have acquired the granulation as fast as possible. And then sometimes you do skin graft after a week or 2 or even 3 weeks. So I think NPWT in conjunction with these kind of scaffold, I think, is very important, not only to prepare the wound, but also to have granulation over hard tissues. Sometimes if you're not going to do flaps, so I think those two parts are important. Of course, if you have hyperbaric, for us, it's to demarcate the wound. Hyperbaric's been used that way. There are a lot of other fancy dressings that are out there, and every dressing has its pros and cons, but I think basically you have to understand how these work, and when you see these kind of diabetic foot, you have to properly understand what dressing is going to help them. And this is why monitoring the wound and looking at the decrease in the rate of size or the change in size is critical to understand whether or not the current regimen is working. So, I hope to see more, state-of-the-art dressings. But right now, I mean, of all the dressings that are being supplied, I don't really see a one that is like critically different from the other dressings.
Mm-hmm.
I mean, we even use a lot of cultured epithelium as a growth factor regimen, but really, I don't know if this is really helping a lot or not.
Got it. Okay, thank you for that. And I think one thing that you just touched on just now in your comments was the importance of ultrasound in your practice. You said look at the velocity of these perforators, and Dr. Hong is not only an expert, obviously, in diabetic foot reconstruction, supramicrosurgery, lymphedema, and so on, but he's also been one of the leaders in the world, thought leaders, as far as advancing the use of ultrasound technology in identifying adequate perforators and identifying adequate lymphatics as well. So I encourage everyone to read his publications on that, and also listen to many of the webinars that he's recorded during these times. Professor Bala, I see you turned your webcam on. Do you have any questions or comments for JP?
Yeah, I have a question. We routinely use collagen granules to improve the granulation tissue in the base of the wound. Do you have any experience on that collagen granules?
Collagen granules.
Yes.
Right. Yeah, we used to have a product a while back. I don't think it's in the market anymore. And it's not only about, it's, they have a lot of, granular products, like they have, dermal allograft granules, they have, bovine collagen granules, and there's many, even pig based, dermal based granules or pastes. And I think these actually are quite useful in wounds with small pits. Like when you have like a small opening after after amputation of the toe, and you have a small unhealed wounds. I think those actually are pretty good scaffolds in enhancing granulation. So to answer your question, I do have use for them in small, deep defects. In
A
those cases,
small
I think, yeah,
in a small
small
ulcer, we use
ulcers,
these
small deep
things here.
ulcers.
They grow
Right.
up and then they may not cover, but at least make the granulation healthy for us to go and do something.
Ultimately, yes. Ultimately, these scaffolds need to be granulated with fresh fibroblasts. So I do think that's very important.
Thank you, Jung. It's an excellent talk.
Thank
Really
you.
enjoyed your talk. Thank you very much.
Thank you for joining.
Excellent.
Thank you.
Thank you for joining us. Well, JP, I wanted to thank you again for taking the time out of your very busy schedule to join us and educate us even more than you already have in the past. It's been an incredible talk, and I'm looking forward to actually having it as part of our video library for everyone to be able to access later and going forward in the future. I'd also like to thank everyone for joining us, and we look forward to seeing you at our next talk, which is actually tomorrow morning. Professor Sanj Kakar from the Mayo Clinic will be discussing ulnar-sighted wrist pain made easy. JP, thanks again. I look forward to hopefully seeing you in person soon. It's been too long. Definitely miss hanging out.
It is. Be healthy, everybody.
All right. Thanks so much. Say hi to everybody at
All
Asan,
right.
okay?
Take care.
All right.
Okay.
Thanks, buddy.
Bye-bye.
Bye.